Greetings, well-being. Season 2, episode 14 of The Pitt is one of the most medically loaded episodes I have ever seen, and I mean that clinically, not dramatically. If you're new here, I'm Dr. Sherazad. I'm a board-certified internal medicine physician, and I watch these medical dramas just so you don't just watch the drama, but you actually learn from it. If this is your first time here, hit subscribe. If you've been here before, leave a comment and let me know what your favorite part of the reaction is. Let's get into it.
What would I feel if it ruptured?
Some chest pain, maybe some shortness of breath for about a minute before you pass down from blood loss.
So let me explain what an aortic aneurysm is. An aorta is a large tube. It's like a pressure hose that comes off the heart, and it's like the superhighway that provides blood flow to the entire body. Think of it like a fire hose with a super high pressure and a constant flow. Now, an aneurysm is when the wall of that hose develops a little weak spot and it balloons a little bit. A weak spot gets bigger and bigger. And here's the part that keeps me up at night and just makes me nervous in general, or anyone in general. That can sit there for years with zero symptoms. It's like a ticking time bomb that you don't know when it would rupture. So it does need frequent monitoring. You need an ultrasound, you need a CT scan. You want to just check the diameter of the aneurysm, because one day that wall can tear and it can cause bleeding within the walls, because within the walls, there's 3 layers. The bleeding could just develop into the chest cavity or your abdomen, and that bleeding happens so fast because think of how much blood is going through that high pressure hose. We're talking like minutes to unconsciousness, sudden death. The mortality rate on a ruptured aortic aneurysm is high, 80 to 90%. It's one of the highest ones. So what does surgery look like to fix the aneurysm once it's reached a specific dilatation? They do a median sternotomy, which is cutting right down the center of your chest. They stop your heart, they open you up, they put you on a cardiopulmonary bypass machine, which is doing the job of the heart and the lungs itself. They put a synthetic tube, basically a piece of metal plastic that replaces the worn out artery. There's one thing I need you to know, well-beings. If your doctor ever tells you you have an aneurysm, you want to keep an eye on it, keep your own notes, and keep track of like when they told you, what date it was, and what they told you specifically. You want to get as many numbers as you can and as specific as possible.
History of hyperlipidemia, an hour of substernal chest pain.
Wow.
Holy shit, what's happening? Mrs. Lynch, VTech.
No pulse, charge to 200.
We have a woman. She presents to the ER with substernal chest pain, 1 hour, persistent pain directly behind the breast. And in her chart, history of hyperlipidemia, high cholesterol. These 2 pieces of information should set up a red flag. Chest pain plus high cholesterol equals a cardiac event unless proven otherwise. You got to get an EKG. For anyone who's ever had one, an EKG is an electrical photo of your heart's electrical system. It's done with stickers and leads that are literally attached to your chest, your arms, and your legs. 12 little stickers are placed in specific spots on your body, and each one reads a different part of your heart's electrical activity from different locations. The machine prints out squiggly lines on graph paper, and these lines tell us, is this person's heart rhythm normal, abnormal, or something very wrong? This woman's EKG looks fine. A lot of times you need to review the EKG with a previous EKG because somebody could just have an abnormal EKG over time. And other things like uncontrolled blood pressure over time can look like they're having a heart attack. Her heart goes into ventricular tachycardia, which is like a lethal rhythm. The ventricles, which are the 2 big pumping chambers on the bottom of the heart, they're not contracting in a way that's coordinated anymore. They're contracting like quivering, actually. So they're not really pushing blood through the body. No blood's going anywhere. This is cardiac arrest territory, when the heart stops.
Charged and clear.
Okay, no signs.
Strong pulse, cycle at BP.
They shock her, they defibrillate her, they put the pads on, and she gets a full heart rhythm back. Now they stop the shock, obviously, because her electrical rhythm of the heart's back.
Repeat that EKG, please, with the leads in the right fucking place.
The EKG leads were placed too low. And this is actually what I was telling someone yesterday, that like a lot of your medical care depends on how well the technician is doing their job. The amount of information that the doctor is reading or going over really depends on what the information shows. So what is a heart attack? When there's a blockage in the blood supply to the heart, in the coronary arteries. When the plaque ruptures and it blocks the blood flow, that causes a piece of the heart to die. That's called ischemia. So the technical term for a heart attack in medicine is called myocardial ischemia. And there's 2 types. The 2 that we commonly learn about are ST elevation myocardial infarctions, STEMIs, or non-ST elevation myocardial infarctions, non-STEMIs. The difference is that there's a time sensitivity to an ST elevation MI. And the only way you know if the patient's having an ST if the EKG is done correctly with the leads in the right place and the EKG shows a STEMI.
It's one inhaler that combines an inhaled corticosteroid with a fast-acting, long-lasting beta agonist. That's fancy talk for an anti-inflammatory and a lung muscle relaxer all rolled into one.
Single maintenance and reliever therapy. That's like one combo inhaler that has 2 purposes. That's really important for this type of patient who has probably moderate intermittent asthma. So how asthma works is you have inflammation of the airways, chronic ongoing inflammation, and it causes bronchoconstriction. So you need a daily controller, usually an inhaled steroid, to prevent that inflammation from escalating. But when you have an acute asthma attack, something triggers the airway to spasm. Everything considers you need a rescue medication now, a beta agonist. That's something like albuterol that opens up the airways. Traditionally, you carry 2 inhalers, one every day and one as needed. One every day means regardless of if you're having symptoms or not. If you can't afford the daily one, or you forget to take it, or you lose it, you end up in this exact situation. But the cost? $400 without insurance. Let that math sit. A child nearly died because his family couldn't afford a $400 inhaler. Not because that inhaler was some exotic foreign treatment. It's because there was no way to open up the lungs that were swollen and shut. Here's the systemic reality. Asthma is not rare. Over 25 million Americans have asthma. 25 million. That's despite decades of guidelines, research, and knowing exactly what to do to prevent asthma deaths. We still have families choosing between medication and rent, and that is not okay.
Is that a trick question or?
Not intended to be, no.
This one got past me.
Tried to keep him here. You even tried to give him a goodie bag when he left. I'm not sure what else you could have done. This was the patient's call. His life, his mistake.
What mistake?
That's like a huge difference that doctors, we get to learn, and it takes so many years to not attach that we did something wrong because a patient chose something differently. And the energy is so real. Remember when Louis wanted to drink alcohol and Robbie was like, oh, well, I don't have to give you the gun to like hurt yourself. Like, I don't have to give you the discharge home so you can go drink alcohol. Like, that was a big deal. And now Samira tried everything. Dr. Mohan, we're on a first name basis. She tried everything, and she really did, to keep him there. He's the DK patient that fell off a ladder. So he's just checking in with her to see how she's doing. Big learning lesson.
There it is, lateral STEMI.
Now that the stickers are put in the right place, they found a lateral STEMI.
Having a heart attack from a blockage in the artery that brings oxygen to your heart vessel.
See, this is different. A STEMI is different. It's a complete blockage, 100% shut. It's not just in any artery. This one is in a coronary artery that supplies the lateral wall of the left ventricle. That muscle's dying in real time. So they picked up the phone and they did a code STEMI.
I think I got kicked in the chest. Normal after a shock to the heart. Family?
I'll leave the defib pads on and take her up in a minute. I'm going to check on a nerve block real quick.
Go.
So she goes straight to the cath lab. The interventional cardiologist, which is not just a regular cardiologist, they are very specialized in interventions like this, either access the artery through the radial artery or through the femoral artery in the groin. They thread a catheter up to the heart. They find the blockage by injecting some contrast. And patients are usually awake for this. Basically inflate a tiny balloon on the tip of that catheter to physically force the blockage open. Then they deploy a stent. It is super cool. I love cardiology. And that stent is actually a metal mesh tube. That mesh keeps the artery open. This is their only shot at salvaging that heart muscle. If she doesn't get to the cath lab fast, the muscle dies. There's a thing called door to balloon time. I don't actually know if it starts when they diagnose the STEMI or when the patient hits the door, but it's called door to balloon time. For STEMI patients, the recommended door to balloon time is 90 minutes. So that means it is heart viable muscle that needs to be addressed now. Shorter times are linked to less mortality directly and obviously reduced cardiac damage. Well-beings, we're not even close to being done. Coming up in this episode is so much more. Stay with me.
Ran into a telephone pole, airbag deployed. Possible C-spine. CT showed unifacet dislocation. Squeeze my hand.
Oh, poor guy.
Real hard.
Oh my gosh, no movement.
10 milligrams dexamethasone.
For spinal injury?
It's compression from a jump facet and maybe some ischemia from kink vessel.
What's happening?
You have a partial dislocation of 2 vertebrae in your neck. It's putting pressure on your spinal cord. We need neurosurgery to screw a clamp into both sides of your skull.
So all of this like diagnosis and treatment plan is being shared so early, and this doesn't really feel very realistic for an emergency room, but a motor vehicle accident where a patient hits a telephone pole at high speed, the airbag deploys, he comes in, the imaging is clear. It shows a cervical spine fracture and spinal cord compression. It means that the vertebrae are dislocating and the bones are crushing the nerve tissue. So dexamethasone is a long-acting, high-potency steroid that will reduce the pressure in the spine.
And then use traction under x-ray guidance to get everything realigned.
Like a chiropractic adjustment?
It's a bit more complicated than that.
Yeah, not like a chiropractor or something. So in med school, we learned that obviously the cervical spine, which is the top of the spine, C3, C4, C5 keeps the diaphragm alive because that's responsible for breathing. And so if there's a transection, which means that a cut between the spinal cord, it's really, really, really concerning. The diaphragm is the main breathing muscle. So he said that he's having some breathing issues. It's controlled by the phrenic nerve. And if those get compressed, this man stops bleeding and he's on a ventilator forever or he doesn't make it.
I think I'm having a panic attack because I can't even get a shallow breath.
Or he's losing C3, 4, 5.
Find Robbie, if he's still here.
What's going on?
Unifacet dislocation, C4, C5.
We need to prepare for intubation.
Any delay in reduction almost guarantees complete spinal cord injury.
What other options do we have?
I saw neurosurgery do a closed reduction once in the ICU.
Blind? That's crazy
Once.
risky.
You gotta do something.
Blind.
You flex the dislocated side and into slide extension.
Quadriplegia if done wrong.
Possibility, sir. It's also the same possibility if we do nothing.
You wanna try?
I've never seen it done. You have.
I can't feel my feet.
Sir, the partial dislocation of the 2 vertebrae in your neck is putting pressure on your spinal cord. I can try to move the neck bones back into place. That could help. There's no guarantees.
Do it, please. Please.
If he gets this wrong, this man is paralyzed forever. If he does nothing, same results. So there's no safe choice here. Season 2, episode 14 gave us so much. We talked about aortic aneurysms and why a 50% chance of death means you run towards surgery, not away from it. We talked about a woman's heart attack that almost went undiagnosed because the system wouldn't ask her to move abroad. And that's why every moment matters in medicine. We talked about a child who almost lost his life because his family couldn't afford a $400 inhaler that's just maintenance therapy. We talked about a man who had DKA that had to choose between his health and his paycheck and why that never should have existed. If something in this episode hit you, comment below. The gender gap in healthcare is real. If this landed for you, I want to know. That's why I do this. See you in the next video. Own your health, own your future.